Hello, welcome everybody. I'm Don Gips, I'm CEO of the Skoll Foundation. And at Skoll, we fund the Skoll Awards, which funds amazing social innovators around the world. And I'm so excited to have 3 of them here with us today. After more than 2 years of fighting a global pandemic, we are able to gather here at Aspen and talk with these amazing health leaders who've been at the forefront of not only addressing the pandemic, but addressing the global health crisis. These 3 leaders are joining us from around the globe. We have Aparna Hegde from Armman, who does most of their work in India. Edith Elliott from Noora, who also does most of their work in India. And Gichaga, who's been leading the finance reforms all across Africa. It's an incredible panel. And each of them is addressing the same huge problem, the lack of global health equity around the world. But you're each doing it from a different angle. They have some commonality in that they're each partnering with frontline healthcare workers, simultaneously working to influence policy and resources at the global level. So, can each of you describe the piece of the problem your solution focuses on, and how you decided that was the problem you were going to dedicate your life and careers to?
Want me to start first? Thank you so much for having me here. So I did my residency in Mumbai in a government hospital where I saw extremely closely how pervasive systemic problems leads to loss of lives of mothers and children due to conditions that are completely preventable and in extremely horrific circumstances. A woman dies in childbirth every 20 minutes in India. 2 children die under age 5 every minute in the country. And almost all these deaths are preventable. And I saw these stories play out daily in my hospital. I sit in antenatal clinics. I was doing my OBGYN residency, sitting in antenatal clinics with 200 patients waiting outside, 300 patients waiting outside. I had not even a minute with them after 5 hours of waiting. And they would never come back. The apathy was too much for them. Right? Only to come back dying in labor or coming back with a child who was malnourished. Many times I have seen a patient dying. I've opened her papers. It is my handwriting. I had seen her in the 3rd month of pregnancy, and she never came back. I was racked with guilt. Did I not counsel her enough? Did I not direct her about what are the risk factors, the danger signs, what are the complications, why she needed to come back for regular care? If only she had the information at the right time, her life would have been saved. If only the health workers had picked up early enough, and diagnosed the risk factor in time, referred in time, so tertiary hospital not overcrowded. Right? So I saw this over and over again, and I realized I have to go into the community to create scalable solutions, given the magnitude of India's problems. And suddenly, mobile phone came to India, right? I realized that it's a wonderful tool to reach out to women directly, right? Using, mobile health technology to their phones directly with information they need, when they need it, in their home. So we have programs that send weekly voice calling services, voice calls, directing them on how to take care of themselves and the child during pregnancy and infancy. And we also have health worker training programs at every level of the health system, the primary care, referral chain, the frontline health workers, the ASHAs, the nurses, the medical officers, and specialists. It really trains them on how to pick up the risk factors and manage in time and refer in time, so there are no delayed or complicated referrals and reduce maternal and child mortality and morbidity. That's what we do.
Amazing. And how many people do you touch?
So our programs have now reached 28 million women in 19 states in the country, and we've trained 230,000 health workers. And our goal by 2030 is to reach 70 million women and their children and train 850,000 health workers.
Edith.
So thank you so much for having us. So as Aparna just so eloquently shared, the health system in India and in Bangladesh, where we work at Noora, is overcrowded, overwhelmed. She's on the front line, sees this every day. Doctors and nurses, and as you just explained, don't have the time to prepare patients, never mind their families, to go home. And so they're leaving these health systems without the information, the tools, the skills that the family needs to take care of the patient when they return home. And it really is the family member who becomes the primary care provider for the patient when they're in the home setting. And in India and in Bangladesh, the family is expected to fetch medications, get food, change the bed sheets very often. But they're really pushed out of the system when it comes to being given information versus brought in. So at Noora, we saw this. We saw that you're lucky if you get less than 2 minutes with a healthcare provider when you're in a hospital in India. We saw that, as you mentioned, the health statistics are startling, and so many of the deaths, whether it be for in maternal and newborn care, in cardiac surgery, you look across the board, most of those deaths are preventable. And what it takes is information given at the right time and in the right way, and not just information, but skill building. And so at Noora, we started engaging family members, bringing them into the system versus pushing them out, engaging families in the care of their loved ones, and the results have been pretty astonishing. So we now are in over 300 hospitals across India and Bangladesh, and we see complication rates reduce dramatically. So in the case of cardiac surgery, you see a 71% reduction in cardiac surgery complications. In the case of maternal and newborn care, an 18% reduction in maternal and newborn mortality. And again, this is all just by bringing the family in, giving them information, skills training in the right way and at the right time. And it's such a simple sort of tweak that now we're working to try to make this the standard across every hospital.
And little known fact, if there are any interns here.
Yes,
Edith?
This is a homecoming for me. I worked at the Aspen Institute my first summer out of college on the Ideas Festival with Kitty and the team, and so it's fun to be back. And then I spent 2 years in DC and got to come here for the summer, so it's fun to be back. Fun to be back here.
Angela, and for those of you who didn't see Angela's panel before this, go watch it on tape. She blew it away. But Angela, over to you.
Thanks, Don. So the problem we are working to solve is multifold. We could have chosen one problem, but alas, we wanted to challenge ourselves. The first is we are reorienting health systems so that, one, that they are responsive to the burden of disease within the continent of Africa, but also that they recognize the beneficiaries as active participants in their own health journey, right? And so we have massively invested in curative care on the continent. However, 50 to 70% of the burden of disease within the continent is preventable. Right? And then we have the similar issues that are being spoken about here. Access to care at formal health facilities is less than what is desired. We have people, more than 50% of the continent does not access the care when they need it at the point of their need. And so we are addressing those financial, those physical, and those social barriers to care. The second is we are rebalancing the power within the public health system on recognizing the role of government as the steward of health systems within their own countries. For a long time, public health and global public health was being driven through parallel systems outside the government, yet we are expecting to hold the government responsible and accountable for the state of public health within their own countries. So that's the second thing we're challenging. The third is we are also trying to challenge who we believe should be at the table in the conversations around development of Africa. We are saying we want to have more people from the global south, especially young people, especially women, and especially women from Africa, as part of international development leadership. So at the Financing Alliance for Health, we are addressing systemic financing challenges of community health systems that should be working at scale and are sustainable and that are government overseen and coordinated. The goal is that community health systems are able to reach people at their household level, at the point of need, at time of need. And majority of the beneficiaries of community health systems are women and our children. We work and embed our team members within ministries of health and finance across the continent to be able to support the government to develop inclusive strategies that make sure that we are able to extend care to the household level to overcome the barriers of access to care. Beyond that, we work at a regional level and at a global level to provide the evidence that community health systems work. We have demonstrated a 10-to-1 return on investment for community health systems in sub-Saharan Africa. We have demonstrated that there is a 4.4 billion annual funding gap for community health systems in sub-Saharan Africa, and we're using that evidence to make the case for increased investment from governments themselves into the systems, but also from the global health architecture. We are also providing financing solutions and instruments that can actually provide funding to governments at the order of magnitude that they require to deploy systems. Governments are not implementing partners and small organizations that you give $1 million and expect miracles to happen. Governments are overseeing millions of people within the country, and so through initiatives such as the Africa Frontline First, we are helping governments tap into multiple billions of dollars, different types of funding from different sources, so that they can deploy the systems at the scale that are required to get the results that are happening. And then we join our voices in advocacy with others like Edith and Aparna to make sure that global health is seen as a strong investment case to keep us all safe, not just in our health sectors, but in all the other sectors in the world. We just saw what happened with the pandemic.
And I wanted to follow up on the Africa Frontline Fund because Skoll has just committed $10 million to this fund. Can you describe it a little bit more?
And we are grateful for partners like Skoll and others who have invested in the Africa Frontline First initiative. So the Africa Frontline First is an initiative that will support 10 countries in sub-Saharan Africa to deploy 200,000 community health workers, so that's creating 200,000 jobs by 2030, reaching about 100 million people on the continent with essential health services and also community-based surveillance. The goal of the Africa Frontline First is to bring different types of money and different forms of funding to government to coordinate, and then the government, together with other players within the country, will be able to deliver services at the household level, at the community level, and also at the primary healthcare facility level. Our goal is to make sure that not where you live does not determine if you live, right? We want to hold the government accountable, but also support them to meet their mandate of providing health as a right to all their citizens within the country. And it's quality healthcare at the time and point of need.
Anybody who wants to know more about this fund, we encourage you to come talk to either of us. I think it's one of the most revolutionary efforts to redesign healthcare in Africa. And huge credit to Angela for being at the forefront of helping drive that. I want to talk a little bit about the pandemic. Each of you was sort of at the front line of fighting and responding to this pandemic, which unfortunately, we don't know when it's going to end or what the next round will be like. But we do know that it has exposed incredible inequity, both here in the US, but even more so globally, with now over 150 million people being pushed back into poverty globally as a result of the pandemic, and that number is growing by the day. I'd love for each of you to talk about how you experienced the pandemic in your work, and whether you think we're learning, what lessons did you learn, and whether you think globally we're learning lessons from it.
During the pandemic, I had two-front exposure to it, right? As a frontline health worker, I'm a doctor in a government hospital. I work full-time, so I was a frontline warrior. So I worked in a COVID ward for 8 months, seeing patients. And Armman was creating solutions countrywide to help mothers and children impacted by the pandemic. What we saw during the pandemic was the lockdown was announced suddenly. People are not given time, right? And lockdown was announced in places where healthcare was needed the most and where the access was least, in the slums of Mumbai and Delhi. Suddenly, women did not know where to go, right? Pregnancy and infancy cannot wait for the lockdown. You have an emergency, you bleed, you need to go out, but you can't go out. There is no transportation. They don't have cars. There is no ambulances. The hospital they are registered in suddenly closed and become a COVID center. They don't know where to go for ultrasound. So we saw this daily, And the thing is that since we have this huge network, right? So our program, Skillkari, is in collaboration with Government of India, where we send information to women directly. And Mobile Academy, which trains health workers, again, is in collaboration with Government of India. And what we saw was suddenly we got calls from women that we were serving, because we have this live database of women we are serving. Suddenly calls were coming in, distress calls. Right now, where do I go? What do I do? I've gone to a hospital, I've turned back. Women who had twin pregnancies in labor were turned back because it had become a COVID war. So we had to really up our game. But the good thing was, because we have this network through the country, right? We have this network of 100 hospitals, 40 NGO partners, the government health system, the entire ASHA network of Government of India, the Auxiliary Nurse Midwife network of the Government of India. Suddenly, because we could, within a couple of days, create programs to meet the challenge. The first thing we did was we created a virtual clinic. We have a call center which is manned by regular counselors, but we then had a virtual clinic because the queries coming in were of medical nature. So overnight, 60 doctors volunteered, and day and night, any mother, any child with a problem was serviced. So 20,600 women got emergency care from doctors, and 60,000 women were linked to emergency health services. And we have so many stories of lives being saved because of that, right? Because they could then know where to go, where to get an ambulance, and what needs immediate care, and what can be managed at home. That is one thing. And we have this live voice calling service. We're going to 1.4 million women at that particular point in time. We added COVID content. Because if you realize, second wave was very bad for pregnant women. They were dying in greater numbers. So we had COVID content which is changing every 6 weeks to meet the current situation. Right? Next is, because we have this live network of health workers through the country, government came to us, and we were sending information to health workers as things change. So over 800,000 health workers, we send information, and many things, right? How to take care of their villages during COVID times, how to take care of post-COVID, post-lockdown phase, right? How to manage stigma, so many things that the government need to tell the health workers day to day. We would send that information. And then when the vaccination campaign started, what we did was that literally, government came to us to send information to the ASHA workers, the nurses, to motivate people to come for vaccination. So there is this Har Ghar Dastak, right? Every family gets vaccination campaign in the Government of India. We sent 4.1 million calls to the health workers, 1.3 million ASHA workers, and 420,000 nurses got calls from us to motivate them to get the women and families, not just women, the entire families back in for vaccination. We've added COVID content to a health worker training program, right? Both for the frontline health workers and the nurses, right? And we have face-to-face training in multiple areas. And this is an ongoing process and one thing we've done now, what we learned from the pandemic is, so our mobile academy platform for nurses and the health workers was a one-time training. But going forward, government has given us a permission to go into long-term hand-holding. So what we want to do is that every ASHA in the country, every nurse in the country is on a live platform with us. So anytime there's new training to be done, they're able to kind of reach out to them immediately, right? So this is going to be multimedia-based, two-way communication, long-term hand-holding. So next time there's a pandemic, next time there is a new vaccine that comes out, we can immediately send out information, and they always trust us because they're always learning from us.
Edith?
So when COVID hit, I'm sure everyone in this room found themselves either as a caregiver or as a patient at some point through the pandemic, or someone you loved was suffering. And for us, the lesson in the early stages of the pandemic when the lockdowns hit was people were still going to the hospital, as you said. People still needed to access care. If you have a heart attack, you still have to go to the hospital. Yes, many of the hospitals were turned into COVID-only wards, but many of them remained operational. And for us, one of the initial focuses was to make sure that our nurses, the people who are delivering this training day in and day out to families, had the information that they needed so that when that pregnant woman comes in, they're not just being given information on the pregnancy and on the newborn and taking care of themselves, the newborn. When that father comes in, or the grandmother, or the mother-in-law, the CEO of all things baby in India, but they were also getting information on COVID and how to keep the pregnant woman safe, how to keep the newborn safe. If you live in a home that is very small, which most of our community does, and you have only one room in that home, how are you going to quarantine if one of the people in your home falls ill? What do you do? So trying to create information that was very relevant, hyper-relevant, not just the information that initially the government was pushing out about, wash your hands and make sure that you're social distancing, which in India is virtually impossible half of the time, but really concrete information that people could get. So our first step was to develop content and material that was relevant and that could be used by frontline workers, by our nurses, who are the ones who are delivering our training day in and day out. And then second to that, we of course were hearing from our community that people were in their homes and needed information quickly. They needed information in the moment. And so we developed a teletraining service whereby we receive phone numbers from the government of families of someone who's tested positive for COVID. We have the phone number for the patient. We get access to the phone number for the caregiver. And we do a live teletraining for the caregiver in the home, and the patient, of course, if they want. And what we saw through that was a dramatic decrease in hospitalization. As hospitals and clinics and health centers were being overwhelmed, the most important thing in those early phases and throughout the pandemic has been to keep people home as long as you can, and for people to know very clearly if and when they needed to access further care. And so through the teletraining, we saw a 48% reduction in hospitalization. And what that told us was, again, family members are frontline health workers. This is a part of the healthcare ecosystem that, if tapped into in a really thoughtful way, if given agency in the right way and again at the right time, can have a massive dramatic impact on the health system. And so hundreds of thousands of families, we still, every day we're receiving phone numbers from the government because COVID has not disappeared, it has not gone away, though our masks might have, particularly in India and Bangladesh. COVID is still very much a part of our day-to-day. So, initially it was about creating material where we've gotten pretty good at Noora at taking complex medical information and putting it through our creative filters to have relevant information in the right language that speaks to the foods that you actually eat in your home, or the situation that you might be in as a pregnant woman or someone who's just had a heart attack or whatever it might be. And then it was really gaining access to people in their homes. And for us, one of the most remarkable pieces of evidence that this solution, this idea, holds true value is that through the pandemic, our group of over 6,000 nurses in India continued to run sessions with families, even though they were so overwhelmed, they were so slammed in these health systems. They still, every day, gather families, teach them the information. And when we speak to our nurses, because it's not Noora team, I know we'll talk about the government in a bit, but we've really aimed to create a solution that if Noora disappears and we walk away, this is something that continues to run with or without us. That's been our aim from day one, working with and through the government in collaboration. And so that nurses were continuing to take the time to make sure that families had access to this information and these skills was really a testament, I think, to how, once you see that change, once you see the difference that bringing the family in makes for the healthcare provider, it becomes a priority because we are all caregivers and we are all part of that healthcare team.
And as you've often said, the power of love is...
It's the power of love, exactly. No one will take care of a patient better than the person who loves them the most, right? You just might not have the information. But what we've seen is, so much of what drives death and dying in these settings, a lot of it is pretty simple. It's not something that the doctor or the nurse has to do. It's something that you or I can do. I'm not a trained healthcare professional, but I can absolutely make sure that a wound stays clean and that if a warning sign pops up, I'm going to recognize my husband slurring his speech before a doctor does. So if given information, and especially during COVID, this became all the more evident, you can do pretty amazing things. There's a lot that has to stick with you, doctors and nurses, that we don't want to touch, but there's a lot that that doesn't have to.
Angela.
The pandemic was quite interesting for our work on multiple levels. The first one is, for a long time, people think, we can do without the government, right? Like, we don't need the government. We have private hospitals. I have insurance. I'm good to go. Then a pandemic hits. What's the first thing everyone does? They look at the government. What do we do? Like, give us direction. What do we do? How do we do it? So the idea around supporting a government to be able to be that steward of health and saying, okay, we're going to shelter in place. People need to have lockdowns. We need to do, even the private sector players, even the implementing partners, all of us were looking for that direction from government. So again, we shouldn't be waiting for situations of crisis to be like, oh, now we need the government. No, the government is required throughout. The government should be strengthened throughout the time. Then, of course, their role will change at different types of the health journey of people, but we need to continue investing in supporting the government to have the skills, expertise, and access to be able to tell people what to do. So that's the first thing. If there's a way of validating our model, because we work exclusively with governments, that was one. Like, people were asking the government, what do we do, right? Then the second was the guidance within COVID was shelter in place. Don't go to the hospitals, right? And we had for a long time associated health with who should provide it, where it should be provided. It's provided by healthcare workers, and it's provided at health facilities. But here is a pandemic, and people are being told, oh no, do not go to where you think health should be sought. Stay in your homes, right? So how do we actually change this situation of health care, which is a service delivery, to actually the state of being in health, the state of wellness? And I think that was really reinforced during the pandemic. And what happened? Multiple things. The first thing was, now, as Aparna and Elliott has said, there were many people who still needed services. It's not like no, people didn't need to be vaccinated, people didn't need their diabetes medicine, right? But they could not go to the health facility, right? They could not actually get to where they were told health is sought, which is a health facility. And so now we had a lot of the governments activating their volunteer community health workers to be able to sustain essential health services. And a lot has been published on this. In countries, for example, like Liberia, there wasn't a drop in the malaria services and cases that were tapped. These people were not going to hospital, right? But there was a community health worker who knew all the people in their household and was still going door to door providing essential health services. What is the second fold aspect? People are being told isolate, and then, oh, we have found one person with COVID. Now we need to contact trace. I mean, the ratio of epidemiologists to the population in Africa is very low, right? And so what happened was community health workers were trained, and they were actually being used to do the contact tracing door to door within their communities, okay? Again, a healthcare worker at the front line who for a long time is told, oh, your role is very limited, but now anytime in a crisis, they're being activated within the communities and being told, go to door and make sure that we are able to know who the contacts of this particular case of COVID is. The third was, so that not only are they maintaining health services, they're doing what is known as community-based surveillance. And so, yes, they might not know, okay, this is a high fever. Is it COVID? Is it pneumonia? Is it malaria? Is it like, they may not be able to know, and the case definition might be very confusing. But one thing a community health worker will know before the health facility is where there's a cluster of deaths, right? 2, 3, 4, 5 people in my community and they're like, neighbors have died, this is a problem. I alert the health facility, and then the health facility is able to come and say, there's a situation here, there's a pandemic, we need to take samples, we need to take them to the facility. So again, the role of community health workers in pandemic preparedness and response was actually also strengthened within the time of COVID. And the third thing is the evidence we have been generating for a long time. Now, entities were coming to us, right? We had primary data from multiple countries, from multiple governments about what it costs to actually train and support a community health worker across the continent. So we had entities like the Africa CDC reaching out and saying, can we access your database of information on what does it cost to train a community? We need to activate through our PACT program, community health workers across the continent. And we're able to provide that evidence and database of costing that then they use to actually deploy about 18, I think now there are almost 20,000 community health workers that did more than 2 million household visits as part of the Africa CDC's program of testing and tracing and contacting people. The last thing was, then the vaccine came, okay? So we fought for a long time, and then we're told the only vaccine you can get is AstraZeneca, live with it. So fine, we get the vaccine. And now people are like, oh, we don't want to get this vaccine, right? And this is very strange, because as a continent, we are very highly vaccinated, right? I think we get vaccinated for everything under the sun and more, right? But for some reason, everyone was like, there's something wrong with this COVID vaccine. And so the health workers, no, just come. They're like, no, if malaria vaccine has taken this long, if HIV vaccine has taken this long to develop, you're telling me this vaccine that you have developed, like there's a problem, right? So there's a lot of miscommunication. And again, as health workers, and I'm a health worker, it's challenging for us to break down information, as Elliott has said, in a way that families can understand. And so community health workers, again, were used to actually be able to counter the misinformation in communities and actually refer patients for vaccinations. And when they were leveraged, we saw the drastic increase in the number of people getting the COVID vaccine. So again, our evidence, our support for governments, and also advocating for community health workers was really validated during the time of pandemic.
So I'm going to open it up for questions in 1 minute. But I just wanted to point out, each of you, as you each are tackling this problem differently, but you each started by working with government, assembling data, but also engaging those closest to the problem, the community health workers, the families. Any comment on that, and then we'll open it up for questions.
So just two comments. When we started Armman, it was very clear to me, to build scale, you have to work with the government. You cannot build parallel infrastructure. I completely agree with Angela. She lives in Africa, I lived in India. We both came to the same conclusion independently, right? So all our programs, so Kilkari is in collaboration with Government of India, where we send information directly to women. And government has agreed for us now to go on to multimedia approaches, two-way communication, long-term hand-holding, and a fit-for-purpose approach. If you have a high-risk factor, if you're equity encumbered, then you're going to have more hand-holding, more two-way communication, more lateral approaches to self-help women's groups. And here we have collaboration between two different Government of India departments, the Ministry of Health and Family Welfare and the National Rural Development, and bringing convergence between the two for the equity encumbered areas, right? So it's very important. Same thing with the health worker network. We didn't build our own parallel network. Our approach to women is to the health workers of the Government of India, and our health worker training program is for the Government of India health workers. The ASHAs in every village, the nurses, the auxiliary nurse midwife, who's the first health worker the woman meets, the medical officers, and the specialists, right? And we're creating this whole system which will now spread through the country in the next 5 years. We've got the mandate from the government to do that. Lastly, what we're doing is that the data is taken for the women from the live database of mothers and children of the Government of India. Now, that database is extremely important because if a woman is not in that database, she is unrecognized. No one knows what has happened to her. Now, our program, Kilkari, takes data from that, looks at the data, improves the quality, sends back the data to the health workers at every level, the health cadre, to ensure that there is improvement in the data. So more and more marginalized women are going to become a part of the system. So not only will they get our services, their entire ecosystem improves. They have a bank account that's created, they get a social security number. Other programs can go to them better because they're part of the database. So, and secondly, we're doing a lot of work on ensuring that there's data-driven approaches at that level of the health workers, meaning we are analyzing data, we're sending it back to the health workers at every level. So that they can use the data that they collect. Till now, they were collecting data, sending it up, but no one had any exposure to data analyzed back at their level. So it's going to be data driven back to them so that they can use the data to improve their services. And we are improving review processes. At every level of the health system, these programs are going to get reviewed better so that there is a push and pull for improvement. Lastly, we're going to be integrating databases. All of these programs work in their own silos. But government has given the mandate now to integrate data of Kilkari, women data, with the health worker data and link them up. So that what will happen is we have targeted programming. For example, a part of the country does very poorly in pregnancy-induced hypertension. Through Kilkari, we can inform the women more. So the Mobile Academy program, we can train the ASHAs more. And through the integrated high-risk pregnancy management for the upper streams of healthcare network, we can train the nurses, the medical office specialists more. And we've got AI integrated because we work with big data. We have a long-term collaboration with Google and Harvard to include AI. So we can predict better and create targeted programming.
Wonderful. I'm doing a bad job as moderator, so I want to open it up for questions. The mic's running around.
Lola Adejokan, I'm the executive director of the Aspen Global Innovators Group. What an incredible panel of solutions and also women leaders. I question you just noted around data and data use. One, I would love to understand how you socialize the use of data, train community leaders on how to process that data, and also how you go about financing growing new data systems. That's no small feat, and systems that are connected to government systems, which tend to be weak, can be difficult. So if you could just talk a little bit about that. Thank you so much.
So a couple of things. One, people want to fund things that are sexy. I don't know if I can use that word. Is it wrong? And data, I mean, technology is sexy, but research and information is not sexy, right? So that's the first thing. And then the second thing is people then decide the one who has the most data, and most of the times in a country, the government actually has the most data. Not that it's quality data, but they do have the data, is that they then say, we need to have better data, and so let's develop a parallel system. And so what we have been doing is saying, we want to be able to improve the data within government. And so we help the government actually revise its data. So now we are not data scientists, we are not people in the information space. But what we do is we help government understand how their data can build a strong investment case to be able to get funding for other programs. And that's our angle to the work.
So I just want to add here. Oh yeah, Edith, you want to add?
Go ahead.
No, please, please.
Well, one interesting point to make also is that typically governments are not very good at collecting data, as we know, never mind analyzing it. And so what we found, unfortunately, was that we had to, in order to come up with the sort of proof points that we needed to convince the government initially, we had to conduct our own research and validate the data that was coming out of the government, or then go to them and say, actually our findings are X, Y, and Z for this reason. So that all had to be financed through philanthropy in our case. But then once we were able to come with that to the government of India, to the state governments, and say, look at this, work in collaboration with us to rebuild your system in some cases, or rethink the system, or add this question to your data sets, then that's where we've been able to open doors and then gain access to unbelievable sets of data that we can then amplify and uplift and make more actionable for the folks who are in charge of taking hard decisions or important decisions. And one really important thing, I think what you said, Angela, about not creating in parallel. So for us, from the get-go, it was so important to not build something that was going to cost the government more money or make them collect data in a different way. And so designing through the existing system. So in our case saying, okay, Noora Health can't place a trainer in every ward in every hospital across India. That's ludicrous. But what we can do is solve a problem for the nurses who are stretched for time. We can solve a problem for the hospital administrator by making sure that they're meeting better health outcomes. And looking at a data set and thinking about, okay, how can we solve for all of these, ultimately, yes, our goal is to reduce death and dying, but looking across the system and saying, you know what, that health administrator, actually what he cares about when looking at the data is not going to be the improvements in exclusive breastfeeding. What he wants to see is our families and patients, are they happier so they're coming to his hospital more often? Even in the government setting, that for whatever reason becomes important and is something that's looked at when they're being assessed. And so having access in our case has always been one of the most important first steps, and then working with the government to help.
Yeah, I just add a couple of points here. We work with the government purely, right? And the funding comes from the government. We only fund our own staff because we want to keep innovation in our hands. But the infrastructure, the database, everything is housed by the government. Now, the government of India has a live reproductive and child health database of mothers and children. That is very poor quality. But because we do Kilkari program that takes data from that, it is one tool to analyze the data, send it back as feedback loop, and send it back as feedback loop at every level. From the state, from the central level to the state level to district level to taluka level to the ASHA worker. We are going ahead to now match each woman to the ASHA worker. So the woman, ASHA will then get data on what is happening to the women in her village. This visibility they didn't have before. Now, and that is why the data quality is so poor, because they don't understand the need for data. Once you send the data back to them, connect them to the women, tell them what is happening with the women, who have the risk factors, that's when they get motivated and understand, okay, this data is going to help me in my work. I can prioritize here. And Government of India has given us a go-ahead for this, right? So this is how, and the financing is from them. Right? But because we are funding our own staff, the innovation pilots, all we can do ourselves. Yeah. I mean, and because we have this long-term collaboration, Government of India, it's inbuilt in our memorandum of understanding that we'll be iteratively improving this whole process.
Yeah.
Incredible. We had a question over here.
Benji Villiers, I'm the Senior Advisor for High School through College Programming at Cooper and College Scholars. One thing I heard in all of your comments was this need to get information to communities. How much of a challenge it is to get communities to buy into that source of information? So I think about my own family who's from Haiti, and so during the pandemic, they relied more on WhatsApp and Facebook as their primary source for what I should do to take care of myself. And even though I was pushing them to say, let's go to the CDC website, there's this innate trust in the community where we've built around this line of communication. So I would imagine that's a huge difficulty as you're trying to get your communities to buy into the reliable information that you're trying to provide.
Yep. For us, that's why we work both with the government and community health workers. So I'll talk about community health workers. Community health workers are members of a community that the community elect to represent them to help them advocate for their own health. And those members of the community are then trained on basic health care. So you're right, there was massive mistrust of governments, our primary client, but there was a lot of trust in the community health workers that we actually leverage to deliver services. And so how do we connect the community health workers with the government so that the government then is able to say, this is what is important, and the community health workers is able to translate that in a way that the community will understand, but they're also able to give feedback to the government from the community. And that's our work. How do we link the government, because it seemed to be far removed from what's happening on the ground, with people who are literally the ground on the ground, and how do we actually narrow that space? So for us, we realized that there was mistrust in the communication that was coming from government, but because we are working with community health workers, we needed to just make the message get to the community health workers, and they that are the ones who translated it in the way that the community can accept it.
Either of you want to add to that?
I mean, in India, the number of myths, the mistrust that it very quickly and immediately was bubbling up was remarkable. And so this is where, when we took a step back and thought about how can we be, what can we add here from a content perspective, we went back to our roots, which are in design thinking, and looked at, okay, what is the myth? What is driving that myth? Who is promoting it? Where is it being promoted? Is it on WhatsApp? Is it through, what channel is it going through? And then designing information to be directly addressing those myths, that misinformation, was how we found, and through our vast networks, right? Because we had this incredibly, this massive network, both of existing families who we had reached, and then an unbelievable network of nurses who day in and day out were having to combat these myths, or people in their homes with a COVID positive patient getting the message that had been sent to thousands of people, forwarded to thousands of people on WhatsApp. And so using design principles, deep empathetic listening, understanding, okay, so why do you trust that message that's coming to you? What is it about that message that is more trustworthy than the CDC? And then packaging information in such a way that directly addresses that. And again, making sure that information is in local language, addressing local, hyper local issues, not blanket statements, not, again, I'll go back to like wash your hands, social distance. These things don't work when you're in a slum in Mumbai. There are things that you can or cannot do, and it's going to be you're absolutely going to listen to your neighbor before you listen to the government. And so it was all tapping into the networks of trust that we already had and making sure that any information was coming from those networks of trust. And going back to, this is something we deal with day in and day out from the beginning of our work. There are so many existing myths and interesting practices around childbirth in India. And so we learned early on how to package information for the grandmother who's accompanying the new mother when she's giving birth, who had maybe 6 kids and did this with her 6 kids. And now a nurse is telling her, don't put dung on the umbilical cord because it can lead to umbilical cord infection. And instead of saying, don't do this, having the information packaged in such a way that it actually resonates with that woman, giving an example from the nurse's own experience of a baby who has experienced an infection because of that. So there are creative ways to tap into those networks of trust, or what we fell back on.
And just I see the timekeepers waving at us. I just want to quickly thank these incredible women leaders who have provided innovative solutions, fighting around the world. Skoll feels so blessed to be able to partner with all of you, and I'd love a round of applause for our 3 panelists.